Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Welcome to another episode. Today I'm with Doctors Jenzer and Elisa Hannan. Excited to do another medicine topic. But Lisa, this is her first time on the podcast with us. So great to have you. Would you be able just to do a brief intro, kind of what you're up to and where you're practicing?
Yeah, of course. I'm honored to be here. I'm Elisa Hannan. I'm originally from upstate New York. I did my undergraduate training at Lemoyne College in Syracuse. I then completed dental school at the University of Connecticut. Then went down south and did 6 years of training at the University of North Carolina at Chapel Hill. That's where I was able to become friends with Dr. Jenzer. And then I moved back to the Northeast and currently work in Avon, Connecticut, which is Northwestern Connecticut. I have a hybrid private practice setting right now. So I still take trauma call and infection call and do larger cases with the residents over at UConn. I'm honored to be a guest here. I've listened to this podcast ever since I've been a resident. Definitely helpful for boards, which I just took this past February, and really interested in all the things that Dr. Roger Levin has to say recently. So stoked to be here.
Those are good ones. Good. Yeah, I appreciate you guys doing these medicine podcasts. I always get great feedback. They're very information heavy, and I think a lot of people appreciate that. So you ready for this? So our topic today was medical emergencies. Do you want to start us off, Andrew, or what are your thoughts on this one?
Absolutely. I'm so happy to have my friend Lisa here. She is one of the best at doing the boards things. We kind of practiced together, did some mock cases, and I've known her for a few years at UNC. So I was super excited to get her on and be a part of this. Let's see, just a couple update things. Yeah, appreciate the wonderful feedback, folks out there. I have a baby girl on the way coming in early July, so maybe I can play these episodes to put her to sleep. We'll see if she finds that soothing like other people use this, I imagine. Sometime around the end of July, early August, myself, Matt Pham, and Lisa here are going to do our summer intro session for the oral exam. And really what that is about a 2-hour session where we go over how to study and prepare, some proposed study schedules, how to do group mock cases. It's free, open event. Once I schedule it, we usually kind of push it out to all the PDs and friends. Residents of any level are welcome. If you're interested in seeing the process, I think it's certainly most helpful for folks about to take the exam this next year. But Grant, if you could put my email in the show notes, if you're interested, just shoot me an email and I'll make sure the details get out to you. Everybody is welcome. It's free, just over Zoom. What I selfishly think is the most helpful, the St. Louis Boards Review course. Registration is now open. You can Google STL OMS Review, and that'll be in early October this year in St. Louis. So with myself, as well as some of the amazing folks, Damian Finley, Rob Reddy, Shake, Greg Tentindo, whole crew of amazing folks. We are fast and furiously updating the last draft of the final Blue Book Part 2. So as those edits are finishing up, we're turning in chapters. Our hope is to have it done by the fall. The book is going to be even more amazing. We're spending a tremendous amount of time and effort in adding to it, making it better, revising it, updating it. So be on the lookout for that. Let's see. That's pretty much my usual disclaimer, folks, right? So Lisa and I, we were talking about what to do for this episode. It's going to be a little bit more kind of boards focused in the sense that we're going to kind of hit the high points of the emergencies. Not necessarily a super deep dive, but hopefully you folks listening can, be thinking through your emergency algorithms, both for everyday practice, but, specifically for mock cases and examinations. And I do want to mention that ACLS and PALS gets updated, if you didn't know this, about every 5 years. And I believe from everything I'm tracking and I've seen online that the next update is going to be about October of 2025. And the updates are usually not too substantial. It's usually a couple medication doses. But certainly something to keep an eye out on. And once those new guidelines come out, look at what changes actually came out. Lisa, you kind of want to take it from here? Any other high points or study points you want to talk about? Just big picture?
Yeah, I think broad view, just talking about the updates in 2025 is always something good to keep in the back of your mind, especially if you are going to use this to prepare for boards. We won't really dive into those algorithms, but something you want to tuck away and know pretty cold right before you take boards. I think the Blue Book is an awesome resource, and I think the SDL course was great. I was able to go during my chief year, so I think that's a great, I'll support that for your shameless plug there, Jenzer.
Thank you.
And then another good resource that's kind of a nice bullet point fashion is the AMIS Office Anesthesia Evaluation Manual. It's currently on the 9th edition, so it's published in 2018. But there's a pretty nice appendix back there that kind of breaks all of these medical emergencies into a bullet point, sort of nice summary for you. But before we get started too, just one thing to think about for any of these emergencies, whether it's boards or it's in real life, you kind of want to always stop what you're doing. Pack the site, suction the airway, repeat your objective and subjective examinations, stuff that Jenzer will nail in your head if you ever work with him for boards. But it's really important to verbalize this. And it's helpful too, because now in private practice, you do the same exact thing. You kind of just need to stop, reset, look at your differential diagnosis, keep a cool head, and know when you need to mobilize and activate 911 and call for help with EMS. But with that, I don't have anything else to add, Jenzer, rather than diving on in.
Yeah, as we work through these, it's such an important distinction particularly for like when you're running a mock case, but a particularly stressful decision point in real life about when the emergency is getting bad enough that you decide to activate your emergency response, right? That is a difficult thing to do. Because when you hit that point, you're kind of acknowledging something has gone wrong enough where you need help, right? I think a lot of us and folks in emergencies tend to regress to a misconception of familiarity where you think it's going to be okay, right? Break in a second as those sats are still going down. So I always encourage folks for each of these, think about like in the setting of a mock case, which helps build it in real life. When's that point when you're going to call for help, partner 911 and activate that? Maybe it's something like when the sats are below 70 or in the 60s, or you've tried 2 to 3 interventions and they've failed. But during your practice of emergencies, understanding where that point is super helpful. And then you build it in such a way that it's a reflex so that when the stress of the real life environment is happening, it kind of triggers and you'll take that step where, I would hazard to say that, folks have had issues with that, I'm sure, out there in the past. Not that I have any specific examples, but it's a very stressful decision point. I don't know, Grant, have you ever had to deal with that or, talked about that with friends or colleagues? I think you're on mute, brother.
Sorry about that. Yeah, that's a good point you bring up, because I think, like you're saying, that decision really should be made ahead of time, and you should have this in your mind, because if you haven't kind of all mentally said, okay, here are my, I guess, break points or the things that are going to happen that are going to trigger EMS, I think, like you're saying, you could go much further than you really want to before calling. And so it's good to have some kind of hard stops and say, okay, my SATs are this, or the patient, is experiencing these symptoms, or they're unresponsive. And your staff knows that, because when you're doing all this stuff trying to keep them going, it's helpful to have a staff member say, hey, we just passed that point. Do you want me to call? And then boom, go ahead, call, So it's good to have a team around you that knows what those points are.
Yeah, good call, especially training like that together.
Yeah.
Yeah, that's why it's so important to do these emergency trainings too. So then you can even review as a team at what point should we be activating it, or at what time, if it's been 5 minutes since you've given it a drug or anything like that, so everybody's on the same page.
Yep.
Yeah, Lisa, you want to start us off with the first one?
Sure. The first one is probably one of the most common ones that we all see in our practice, but it's syncope. So what is syncope? Syncope is an abrupt, transient, and complete loss of consciousness secondary to inadequate cerebral blood flow and oxygenation, which is followed by a rapid and spontaneous recovery. So there are technically 3 types. There's cardiac, orthostatic, and reflex, also known as vasovagal, with the vasovagal one being the one that we'll focus on today. The cardiac ones are usually secondary to an arrhythmia or any type of structural heart disease, and the orthostatic ones are more common in older patients where there's failure of the autonomic nervous system to maintain blood pressure. But for thinking about vasovagal, When you're doing your history and physical, a lot of this and a lot of the questions that we'll kind of talk about with the other emergencies, you can screen a lot of patients. So you can ask and kind of determine, it's usually a younger patient, less than 30 years of age, and they usually have previous episodes of having a vasovagal syncope episode. And you can ask them what their triggers are. So for an IV sedation, I frequently say, have you ever given blood before? Or have you had an IV before? If so, how did that go? And then they'll usually tell you if they have terrible needle phobia or they have fainted before. And then you can also ask what other prodromal symptoms they might have, like if they also get blurred vision or nausea and vomiting. So those are some other warning symptoms. Andrew, how does this usually present?
Yeah, exactly right. We see things like facial pallor, they look diaphoretic. We get that, parasympathetic surge causing nausea and vomiting. They can look ashen. They don't feel good if they're, hopefully still awake. And, with that big parasympathetic surge, they're going to get a transient drop in blood pressure and cerebral perfusion. So it can cause a loss of consciousness. It can happen really quickly, 2 to 3 seconds, sometimes a little bit slower, but it can really snap on. And so what do we do about it? Stop what you're doing in terms of the initiation. If you just got the IV in, I wouldn't recommend taking it out. I would definitely leave it in. But you really have to get the patient and get their brain at least level with their heart, ideally down a little bit of Trendelenburg. Support the airway, give them oxygen. Oftentimes, if they're in this normal kind of, I feel really bad, nauseous phase, a cool compress on the forehead, and just watch them for a while. They really should respond to those positional changes within about 30 to 60 seconds. If not, then you have to consider a different thing on your diagnosis. But really identifying this ahead of time, and if they have these, getting them into that physiologic position of the head and brain being equal horizontally with the heart or below prevents this from happening. They literally physiologically cannot pass out and have a full syncopal episode if you have them in the correct position. I have seen it once with asystolic syncopal episode. So that can happen. And then I Googled it and found there's papers on it. It's not horribly uncommon, but IV start within 3 seconds, the patient's heart rate went from about 60 to 0, flatline. We're getting her back real quick. I happen to be walking by the room as my assistants are, we're doing this, and I watch the heart rate go 60, 30, 0. And we start CPR, and, they had the IV in, and somebody runs to grab atropine and get help in the crash cart. And within about 5 seconds of getting correct position and a couple CPR pushes, the heart rate just snapped back up, and we gave atropine. So usually they do self-correct pretty quickly once you get there, but it can be very surprising. So that really kind of, was that lesson in my mind to tell my assistants to really ask those questions. And if somebody has a history of that, start them in that low position. You guys ever seen anything like that? Or I assume, we all have seen some basic, syncopal kind of things.
Yeah, I would add too, just because I tell my staff, they're usually doing the IVs, tell them to kind of prepare for syncope, like you're saying, put them in that position to start with. We have them put the oxygen cannula on, everything before we do the IV. That way, if they do pass out, they're kind of already hooked up to the machine, the oxygen's going, etc. So kind of preparing before you start that process.
Yeah, I would say the same. I have yet to see the asystolic version of this, and hopefully
nobody listening has to do that. Yeah, so good. Yep, if it resolves, syncope. If not, consider other differentials. But when somebody kind of has that initial pass out and if you're asked about what that differential diagnosis is, syncope could definitely be on there. Kind of the nasty one of the ones I really don't like, bronchospasm. This is a reversible reflex spasm of the smooth muscle of the bronchi. Really, we think about this high risk for asthmatic patients because they have the bronchial hyperresponsiveness. Good questions to ask. We want to ask these folks how well controlled they are, recent exacerbations, triggers, who manages them, do they carry their inhaler, how often do they use it, ever been hospitalized or intubated, to try to get an idea about the disease. They have pulmonary function test results. I like to get those, especially if they're bad and managed by a pulmonologist. It can be often a conversation with them. PD patients, about 60% of them have bronchial hyperresponsiveness, so pretty common in that patient population as well. Smokers, right? People or have occupational exposures, tend to have a little bit more just generally irritated lungs and could have the hyperresponsiveness. And similarly, patients with a recent or current upper respiratory infection, within the last 4 weeks, definitely at an increased risk for this. And usually in the context for, what we're talking about, a sedation, it's going to present with wheezing, both inspiratory and expiratory. We may see things like tachypnea, dyspnea, and difficulty ventilating. If we get to that point of using a bag, it might be very tight and difficult to get air in. And on capnography, right, our open circuit end tidal, instead of a nice flat mountaintop rock, we're going to see more of a shark fin. And that's going to indicate something is obstructive, which bronchospasm is usually the most common. How do you treat somebody if they start to have a bronchospasm, Lisa, besides just getting, starting to feel real uncomfortable?
Yeah. So this is one, you want to stop what you're doing, pack the site. You can even, if you're working with a group, you can call just for extra hands too. That's something you can always say during boards if you want to get your partners in the room. But you want to increase their oxygen supplementation, get them up to 100%. You might want to get your ambu bag and some positive pressure ventilation too. You'll probably have a restricted pattern, like you said, and harder time to ventilate these patients. Hopefully someone's grabbing the crash cart for you, because that's likely where you have your albuterol inhaler, because that's our first line treatment. You would want to give 4 to 8 puffs of this albuterol inhaler with a space chamber if your patient is sedated. That works because it's a beta 2 adrenergic agonist. It activates adenylate cyclase and increases intracellular cyclic AMP. This then causes relaxation of the bronchial smooth muscles and hopefully provides relief from your bronchospasm. Other things you can do if you have the IV in place, you can give a steroid. It's not immediate, but you can give Decadron 12 milligrams, which just helps in the long term. If that still doesn't work, this is likely in my algorithm is when I'm going to be activating 911, because I would assume my oxygen saturations might be dipping low at this point. But for refractory cases, you want to reach for epinephrine. Depending if you have an IV or an IM formulation, this is where it gets important about the concentration of epinephrine. So you want to do a 1 to 1,000 concentration if you have an IM form, like an EpiPen. That would be 0.3 milligrams in adults in the vastus lateralis, or a normal EpiPen, or 0.15 milligrams in children greater than 30 kilograms. Again, IM, that's EpiPen Junior. If you have your IV, you can give the IV formulation or concentration, which is 1 to 10,000. For adults, you can give up to like a 1 milligram bolus in adults. You can start at 10 mics too and titrate it as according. And then you can do 10 micrograms per kilograms in children. You can also give diphenhydramine to help with the histamine control. You can give 25 milligrams. And then if that still doesn't work, at this point, definitely EMS should be activated. And this is when you want to gain control of your airway. So we're going to think about intubating the patient. You can reach for your succinylcholine. The intubation dose is 1 to 2 milligrams per kilogram IV. If you lose the IV in this situation, you can always give it IM as well, about 4 milligrams per kilogram. If you're with a child, you might want to consider grabbing atropine as well to help combat the bradycardia, especially in children. And that would be 0.01 milligrams per kilogram. For children, just in my experience and what I did during residency, which I like and I still do, whenever I have a kid or any pediatric patient, whether it's oral sedation or anything IV, I always have a pediatric dose chart that I insert their recent height and weight. And I usually get that the day of surgery, and then I print that out and hang that up on the wall. So that's something nice, even for induction meds. Everything's already pre-calculated for you. But especially if you run into a situation like this, it's really difficult to try to calculate everything and remember all the milligram per kilogram doses.
Nice. Yeah, it's definitely a scary one. And just backing and talking a little bit about a couple of those things. So, it's totally fine and acceptable, and I would and do try albuterol. If they're having a bad bronchospasm, you're not going to be able to get it in. So don't expect that to work or fix it. Your main medicine that's going to fix this is epinephrine. And I really want to harp on that. When I'm running people through a lot of mock emergency scenarios, this is a common point that's misunderstood, right? And Lisa really emphasized it. If you're stabbing epinephrine into an intramuscular area, the concentration is 1 to 1,000. If you're ever putting it through an IV, the concentration is 1 to 10,000. End of story. That's the way it is, right? EpiPens are 1 to 1,000. If you were to put 1 to 1,000 epinephrine through an IV, it would probably cause such an intense vasospasm that you would have vascular damage and other issues. The drugs she mentioned, those ancillary ones, steroids, diphenhydramine. You could even talk about ranitidine for a different H receptor. Those will help kind of down the road at preventing more of that degranulation and histamine release and control, but it's not going to help in the acute phase. You can certainly try to deepen the anesthetic as well with things like propofol, right? We know it has a little bit of bronchial relaxation. It's always kind of a funny point. I don't know about you guys, but just again, now stepping kind of out of boards world, when I start to have emergencies, I'm just hesitant to start pushing deeper and more medicines. It's really not what I prefer to do. because, I like to kind of let them wake up a little bit and hope that the issue passes. So it's something that I have done before and have definitely, I'm aware it's a thing, but I'm curious about in real life how you guys choose to, ride it out, kind of we'll let them wake up, get past their spasm or whatever they're having, or are you guys liking to take them deeper, just kind of how you rock?
I usually have my patients pretty deep at a baseline. So for the next one we talk about laryngospasm, usually I've had this happen a couple times, but I've been able to break it by deeping them with propofol. And just because I have it there and at the ready, and that with a Larson maneuver, I've been successful. For a bronchospasm, I actually haven't been in this situation yet. So I'm not sure what I would do there. Probably similar, I would say. What about you, Grant?
Yeah, I tend to kind of go deeper, um, keep them deep, and then if things are happening, just maintain that level. I was going to ask you, Andrew, so you mentioned both the IM and the IV. Do you have a preference on one or the other? I mean, I have both of those in my cart, but what do you go to first?
Yeah, that's a good question, actually. So if you look at the AAOMS Office Anesthesia Ninth Edition manual, and if you're studying for boards and you're diving into this deeply, you'll see it written a couple different ways, but you'll usually see the first line as being intramuscular. And I don't think one way is necessarily right or wrong. It does make sense to me that in a situation, the fastest thing you'd be able to get ready is probably the EpiPen, or if you're having to stop and draw up something yourself, pulling up 0.3 and then stabbing it in the muscle and giving it is going to be much faster than you doing a quick dilution calculation and figuring out the IV dose. I also think there might be some veracity, and that this is just, I haven't like deep dived this, but you might get a little bit longer effect if you inject it in the muscle. Obviously, epinephrine is really transient, but you can certainly repeat dose that if the spasm gets worse. And then kind of like Lisa mentioned, there's this wide range of what do you actually push and give in terms of how much if you're doing IV boluses. And from my own experience doing this in, mostly kids, you can give little bumps. I think we had a patient in the operating room maybe a week or two ago who started to have some pretty intense bronchospasms. And, talking with anesthesias, they're working through it. And they were given like 20 micrograms, just, a little IV push that really helped break it. Epinephrine just is the main thing that helps break these open. So I don't think there's necessarily a right or wrong. I think most algorithms recommend IM first. But definitely something to think through based on everyone listening, your individual practice and what supplies you have available, or like how are you going to actually physically do that before you have to actually do it.
Yeah, good point. And epi can also be given through an ET tube, right? If you have that established, or what are your thoughts on that one?
Yes, you can. Correct me if I'm wrong, Answer. I don't think of that since boards, but I think it's like it's like a 10 time less dose, I believe, or greater dose. I don't even remember. I've never had to do it. I would resort to an EpiPen in that situation.
Yeah, it's some. I want to say top of my head, maybe like 4 times you need a higher dose, but it's what is it? Lean, like lidocaine, epi, atropine, naloxone, maybe something like that.
Yeah, I can do vasopressin too, I believe.
Yeah.
Naval. It's naval.
There you go. Yeah, D is buried in there. It's the beauty of studying for boards, folks. You just burn these things to your memory, and then it's super good, honestly. And then it starts to fade if you don't use it, which is why we do podcasts.
It's true. I can start off the next one if that works.
Please.
Sure. Next one is kind of the cousin or the sister to the bronchospasm, the laryngospasm. So it is an involuntary forceful contraction of the vocal cords, resulting in an acute obstruction of the upper airway. When you're thinking about patients who are most at risk for this, similar to bronchospasm, you're going to think about maybe your asthmatic patients with certain neurological diseases, like myasthenia gravis or ALS are more prone to this. Patients with GERD and anyone with a recent upper respiratory infection, again, just because they have that bronchial hyperresponsiveness. How does it usually present? Might have a patient that starts coughing. You might hear the inspiratory stridor or the very high-pitched wheezing sound, dyspnea, and then they're going to have a complete lack of movement. Things you can do to prevent this: having a very good throat screen in place and making sure your assistant is ready with the suction when you're irrigating and things like that, because that's an easy one that can stimulate a laryngospasm. Jenzer, you want to talk about treatment?
Yep, nasty old laryngospasms. Like you said before, what do you do when you're starting to get this in that mock case scenario in real life? Stop the surgery, pack the site, suction aggressively, get everything clean. A lot of those precipitating factors is the liquid or the mucus that's there. And we attempt the Larson's maneuver, right? Really putting a lot of pressure to, between the mastoid process, the mandible, nice aggressive jaw thrust, and using that pain to help break it, which most of them do. If it doesn't, or they're still struggling, right, when things start going bad, get the oxygen in. Crank up the oxygen, and if you have to, you can move to bagging. Remember that through usually our nasal cannula wall oxygens, they go up to maybe 6 or 10 liters per minute. Almost all of those go up to 60. So in an emergency, you can keep turning it up, and you will blast more and more oxygen molecules in. And if they're doing their high-pitched crowing, kind of in and out spasming, hopefully you can at least keep dribbling enough oxygen in there to meet the basal metabolic needs. We can talk about, just like Bronco, deepen the anesthetic, and usually that is about 0.5 mg per kg of propofol in terms of a bolus. Then we get to, things are, going bad. It's, sats are probably low. This is probably a point, if I'm thinking about calling EMS or activating a code blue, that we start talking about using a paralytic. 2 different ways we can use that, generally succinylcholine, although you may have others with you like rocuronium. We can use something like 0.5 mg per kg of succinylcholine to break the spasm, or the smaller partial dose, you'll also see just 10 to 20 milligrams. The thought being enough to help relax that, as it's one of the earliest muscles affected, without giving a full paralyzing dose. Or you could give that full intubating dose at about 1 mg per kg. And then, take the airway. Again, just be thinking, especially in kids, I always think about the parasympathetic response that we get with succinylcholine. So if you're giving sucks to a kid, you really need to either give atropine at the same time or have it real ready to prevent that bradycardic response. And then if somebody has a history or suspicion of MH, or some offices are switching to rocuronium, there's a whole detailed discussion in there, but that dose would be about 1 mg per kg. And we have to also watch out and be thinking about negative pressure pulmonary edema, which is a sequela. When that vocal cord snaps shut and they are trying to draw in their lungs, they can do that so hard to get air in that they actually cause negative pressure pulmonary edema. And a lot of that fluid will then mobilize in the interstitial space, and they'll develop essentially ARDS afterward. I have had one once where they had I don't even know which was first, but it was a bronchospasm and laryngospasm. One may have precipitated the other, but finally when the laryngo broke, then it was super hard to bag them and get air in. So then after epi and everything, and it was definitely not a great experience. But I think when these things get bad, especially in young, healthy folks who have a lot of power, you really got to be concerned. And if you have concerns, then that's another reason to call 911, even if it's for a chest x-ray and monitoring for a few hours.
I think that's a good point. I had a case like this, and once we were able to break it, but that's still when I'm activating 911, just because I don't know. You can't predict which patients will get negative pressure pulmonary edema. That's something you definitely don't want to send them home with and have that be an issue. So even if they're admitted overnight, you just sort of explain to the family, but I still activate 911 in that situation as well.
I think I would much rather be embarrassed, and when EMS gets to the office, tell them, hey, I'm sorry, I was, everything is okay now, as opposed to the other way, and then be dealing with a situation where I should have done it and then didn't.
Yeah. What do you think, Grant?
As far as things that, lead more to the propensity of laryngospasm happening, you mentioned, of course, secretions. And so for me, it seems like it's usually a combo of not having a good throat pack, you're drilling, you're not paying attention, all this, fluid and stuff's going in the back. And also too, it seems like if you're using a lot of ketamine or medications that increase secretions, stuff like that, I see just a lot more laryngospasm happening. I think being aware of those things, being careful with the doses of the drugs you're using, really getting to it quick. If you notice them, starting to cough a little bit, not just ignoring that stuff, but getting everything out of the airway, like you're saying, packing it, really getting your yank hour, your saliva ejector, whatever you have, getting that all around, getting them cleaned up. And I think the jaw thrust is key, and the way you do it and popping the jaw forward. And I'm sure we've all been there where we're telling our assistant to thrust and they're not really doing it. They're kind of lifting at the bottom of the chin and not popping but behind the jaw like you were describing, Andrew. So a lot of little technical things that I think if you're doing quickly and right can solve this very fast.
That's a good point. So maybe something we don't talk about enough is the normal things that we do to help prevent getting in these situations. I'm a big fan of my order for thirds is 16, 17, 32, 1. I like to start with an upper tooth, gives me a little confidence. I like to then finish with an upper tooth because I can, lighten the sedation. But the way I mitigate the blood coming down is I tuck a little bit of my gauze up and in there so there's absolutely no blood going into the airway. I tip the head to the side toward my assistant when I'm working on 17, away from me, in order to make sure that the fluid is collected in that space. So maybe like your junior surgeons, there's things you can do to optimize it to really prevent yourself from getting in these situations, which maybe we don't talk about enough, but I'm sure we all do those minute things because we have the experience with it.
For sure. Yeah. Great point.
That's a good point. Even working with residents, and I work with residents now and help with their sedation clinic. But, even when you get started and you're getting comfortable with sedations, getting that patient at a good level and comfortable so it's not a rodeo and you don't have the weeder flying all over the place and the assistant can't even get in the mouth because the patient's moving. All that stuff is just everything can factor into why there's saliva or blood just getting to the back of the airway and being a big issue.
Yeah. All right, let's jump on to the next one here. Seizure. Good old fun seizures. So what is a seizure? It's caused by a sudden onset of abnormal, highly synchronized discharges of neurons. And of course, we have the term that floats with this, epilepsy. What is epilepsy? It's a chronic neurologic disorder characterized by recurrent seizures from congenital or acquired factors in the cerebral cortex. And we have this term status epilepticus. And the American Epilepsy Society defines this, or status epilepticus, as more than 30 minutes of continuous seizure activity or 2 or more sequential seizures without full recovery of consciousness in between. But kind of for practical purposes, it is a neurologic emergency which consists of sustained seizure activity lasting for more than 5 minutes for convulsive status epilepticus, or more than 10 minutes for focal. It has significant morbidity and mortality, and usually is secondary to an abrupt withdrawal of an anti-epileptic medication. And anti-epileptic drugs we often call AEDs. So not to be confused with the AEDs that go on the chest, but all these anti-epileptic drugs. Pro tip, so if you want to use drugs that kind of raise the seizure threshold, things like midazolam, propofol, we really want to avoid certain drugs that lower the seizure threshold, right? Things like ketamine and fumazanil. Ketamine is an controversial. I have actually recently looked at this literature. There is literature that shows that when ketamine is relied on as more of a single source agent, it can contribute to increasing seizures. But there's also evidence that shows that ketamine with other agents lowers or, is more seizure protective. So it's very controversial, but I think there's still enough evidence there where, like, if somebody has epilepsy, I am not going to select ketamine as part of my sedation. But understand that the evidence is weak and it's not great. It's more of like kind of loose thing. But I think it's still enough where personally I wouldn't go against it. And post-operatively, you want to be thinking about your medications, right? Certain narcotics, especially tramadol, can be proconvulsants. Most at risk, so patients with histories of seizures or epilepsy, you want to ask them just about asthma. Ask them all about their seizures. What do they look like? How often they happen? When was the last one? Who follows them, right? Their neurologist or PCP, and get a consultation ideally beforehand. What medications they're on. A lot of times in my experience, seizure patients might not be the best at taking their anti-epileptic drugs. I have dealt with those issues. And how long they've been on them. Because, they really have to titrate them. It's just like thyroid disease. It's often titrating up and down until they kind of stop having seizures. Lisa, you want to take us kind of through how seizures present?
Sure. It really depends on the type of seizure that the patient usually has. So that's why it's so important to get to know this during your history and physical exam and have that documented just so you have something to reference should you be concerned about this. So for convulsive, like status epilepticus, you would anticipate like continuous, repeated, generalized tonic-clonic seizures, often with prominent motor symptoms like rhythmic jerking of the extremities. For the non-convulsive type, this is definitely more subtle and really hard to pick up, especially if this patient's sedated. So if the patient's not sedated, they might have an altered mental status, abnormal ocular movements, lip smacking, and really subtle motor twitches. If you have someone with a history of absence seizures, mostly children, you also have to consider a stroke on your differential diagnosis if you're concerned about this. So for the treatment of this, I like to think of A, B, C, D, E, F, G. So of course you want your ABCs, and then the D, E, F, G always reminds me to don't ever forget the glucose, because hypoglycemia, we'll talk about later, can also present with seizure-like activity. And that's something easy that we can check. So for airway support, especially because these patients might vomit, sticking in a nasal trumpet really quickly, positioning them in the correct position, a lateral decubitus, getting a good suction with a yank hour, and then don't be hesitant to get an advanced airway and securing the airway with a rapid sequence induction, similar to what we talked about before. Obviously, having them hooked up to monitors for circulation. If you have one IV, it's not a bad patient to try to get a second IV in the contralateral arm. Look for reversible causes like hypoglycemia, like we talked about. And then first line, many of us will have Versed, and you want to do 10 milligrams of Versed. And I did a deep dive on this when I was studying for boards. So is that like a 10 milligram bolus? Couldn't really find an answer with this, but I had a situation like this in my office when I first started, but I just added the amount of Versed I would need to get me to 10 milligrams to see if that would help the seizure-like activity. Many of us likely don't have lorazepam, but that's another one that you can give at 0.1 mg per kg. And then second line agents are things that you'll have to get at the hospital. So for these patients, because of the significant morbidity and mortality, we definitely want to activate EMS for this. But usually the hospital might load them up with Keppra or valproate or phenytoin, depending. And then the patients can also be deepened with propofol if you need to. But these are ones you definitely want to monitor, have a good timer, and definitely activate EMS. Anything to add, Jenzer, for those?
No, yeah, it's thinking through some seizure patients that I've had, and I was thinking about, we've been structuring a number of these things, and now we can start to group them into differentials. And I think during the board study process, a way that people get confused is, you study really good so that, like, when I ask you, hey, the patient has a seizure, what are you going to do? You kind of spit out and go down the line. But when I give you kind of vague symptoms and you're not sure about where to go, you are a little uncertain. And as, Lisa went through it, and like, until you have some reps at it, conceptualizing that differential part is part of the emergency management, you might not think about as much. So like that patient passes out or maybe having some seizure-like activity on that differential. We've had 2 of them so far, right? Syncope, as well as seizure, and hypoglycemia, right? Those are all kind of those acute things that, or as well as stroke, as something like that would be a good differential if you start to see that versus, the airway stuff, that laryngo and bronchospasm. And sometimes they can be a little bit more subtle in real life. So I think grouping them in your mind is like, these are how these may present. And then sometimes I've been in situations where I've activated emergency because I don't know. And some of those differentials are pretty nasty, right? It doesn't turn out to be that bad. Or there's I can't even remember what it's called. When your anxiety gives you like a stroke-like symptom, but they're not really faking, but it's like kind of faking, but they present like a stroke. Do you remember what it's called? I'm blanking on it.
I know there's pseudo seizures, which is similar to that, but I can't remember the name of the stroke one.
Yeah. But like when you don't know, you have to treat it like a real one, right? Much better that the patient is having fake seizures or, fake stroke than the real thing. But some of those, if stroke's on your differential or MI and you can't rule it out, pretty damn sure you want to be getting help, ASAP until you then, wipe your sweat off your head afterward and, hope that it's not the bad thing.
Yeah, I think you always do a great job whenever you're working with residents and people for boards. You just want to be a safe surgeon. So what can you do to prove that you are safe? And in real life, if this happened to you, you're going to load the boat and you're going to make sure EMS is called because you don't want to be the one that misses something.
Yeah. We had our graduation dinner last night, my 2 wonderful graduates, and I was talking about how I'm so proud of them as being competent, safe surgeons, right? Really good at critical thinking, and I know they're going to be safe, and that's really important to me, right? And I think all of us, there's nobody who wants to be a not safe surgeon, And I imagine if you're listening to this episode, you also want to be a safe surgeon, which is amazing.
One comment on seizures is, I think we're probably talking about and thinking about these patients being in our chair, with the monitors hooked up and all that stuff. A couple of years ago, we had a patient, who finished a procedure, walked up to the front desk, and the girl at the front claimed that when she told the patient, how much she owed, the patient just collapsed on the ground and went into a seizure. And so I'm doing another procedure in the back office, and someone runs in, "Hey, Dr. Stucki, we need your help." So I go up to the front. There's all these people standing around a patient laying on the ground on her back. She's having a seizure. She's purple. She's foaming at the mouth, and all the secretions are kind of getting stuck in her airway, and she can't breathe. And people are, "Oh my gosh!" And literally just a simple jaw thrust and turn her on her side, and then all of a sudden took that big gasp of air and started breathing. But it just we don't think about sometimes that when they're laying on their back and all of the secretions start happening, that typical foaming at the mouth thing, you really need to control the airway quickly and get them into a position where they can breathe. Any
Wow.
thoughts on that one?
I thought you were gonna go with it was like a fake one, but no, this sounds like a real, like that's wow.
Oh yeah, for sure, a real seizure. So that told me we need to decrease our prices so that when they get to the front, they tell them the bill. It's not, oh my gosh. But yeah, we get the oxygen, the crash car, we call EMS, the patient are being fine. But one of those things that a lot of people kind of start panicking when they see someone seizuring on the ground. They don't know what to do.
Yeah. And actually, that brings up a really good point that I like to throw at folks during mock cases is what if you were doing a sedation and then you have an emergency outside of that? And really, if you're in a sedation and you're managing that patient, you really shouldn't leave that patient to go deal with something else. You hope you have a partner or a nurse, or obviously, if you're solo in real life, making sure that patient is recovered before moving on. But that is definitely a situation that I advise you to think through how you're going to answer that. It's a kind of tricky one I like to throw into mock emergency cases to see what folks will do. And even if that might be your office folks are calling 911 and managing it to the best of their abilities until, obviously if you're doing local, it's a lot easier. You can leave and go out, but it's a good kind of tertiary emergency thought process to go through for the folks listening as you prep.
For sure.
All right, Lisa, you want to talk about good old myocardial infarctions?
Sure. So MIs. So what is it? It's an infarct to the myocardium secondary to hypoperfusion of the coronary arterial system. To be diagnosed with an MI, you technically need to have 2 of the 3 criteria according to the World Health Organization. So you need to have angina that's consistent with ischemia. You should have elevated cardiac markers, which you'll find out in the ED, things like troponin, CKMB, or myoglobin, and then characteristic changes on your EKG. So you might have an NSTEMI versus a STEMI. So an NSTEMI is a non-ST elevated MI, which represents a subendocardial infarct, versus a STEMI, or the ST elevated version, which is a true transmural infarct involving the entire wall of the myocardium. When you're thinking of the patients who are most at risk, older patients are more at risk, males are more likely than females, anyone with a positive family history of CAD, a smoker, anyone who's hypertensive, anyone with dyslipidemia, so elevated LDL levels and low HDL. Think of sort of a metabolic syndrome. Those patients have a big contribution in why they would have more atherosclerotic plaques. Diabetic, anyone who's obese, CKD, anyone with a previous MI or CAD disease. Again, similar to the asthmatics, similar to the epileptics. Ask about who treats them, who follows them, is it a cardiologist or just their PCP. Try to ask what their metabolic equivalents are. So ask what their functional limitations are. Can they walk up a couple flights of stairs? Can they do yard work? All things that I like to ask and document in my history and physical appointments. You can try to stratify them, the New York Heart Association risk, if you know they have a history, a significant cardiac history. And then you can discuss optimization with their cardiologist as well. It's always good to reach out to them if you're truly concerned. Think about lifestyle factors too, especially if you have a patient who abuses cocaine, because they're much more likely to have more cardiac issues in your chair. Jenzer, you want to talk about how this usually presents?
Yep. Got to be aware of the folks on the booger, sugar, or disco dust. It presents a range of symptoms, typical versus atypical. We often think of the male presentation of the sense of impending doom, the crushing chest pain, the left side, the radiating pain, but tightness, squeezing, burning, kind of anywhere in the abdomen up to the chest and thorax, nausea, vomiting. Females, though, and other people, these can present weirdly, right? It can just be kind of epigastric pain, and that's why on that acute differential, things like an aortic dissection or MI always have to be ruled out. Like my patient who I had once who just had TMJ pain is the sole presenting sign of infarction of their left coronary vessels. So it can present with a range. And, we're talking about it like mostly like they're awake and not necessarily sedated here. Treatment, right? So we think about ONAM as kind of common. Now, I do want to caveat this and say that some of the recent literature is, and I'm going to discuss some of this as it's shifting. Good thing, first of all, to remember that when patients have cardiac issues, we really want to limit the amount of epinephrine we give to about 40 micrograms or less, which is about 2 carps of 2% lidocaine, 1/100,000. It's about 18 micrograms per carp, depending on how you do that calculation. There's a little bit of variability. 1.8 versus 1.7 cc's. The literature is not good to support that recommendation. However, it is kind of one of those things where, if you use more than you should and go against dogma and then you have a problem, I don't know how that would look in a medical legal situation. But the evidence for that, like most of our local stuff, is garbage. If you actually go through and look at it, it's mostly just like Malamed's book and then a couple animal studies. So it's hard because the evidence isn't great. I still follow it myself and am careful with that. Do things in quads, augment with things like plain carbocaine. When you start to get concerned about the NMI, right? Number one, stop, pack the site, suction, get the airway nice and good, activate EMS, get help on the way. Of course, check the pulse, see if we're going into an ACLS kind of algorithm here. Oxygen. When we start to talk about ONAM, the current recommendation is only to keep the SATs at about 92 to 94. Oxygen, and just like fluids, is a drug. So we really don't want to just crank the oxygen and flood them in these situations because the outcomes have actually shown it's not good. It increases mortality. Nitroglycerin, right? 4 milligram sublingual tablets. You can give these every 5 minutes up to 3 doses. However, you cannot give nitroglycerin. It's contraindicated in a couple situations. One, if they're hypotensive, and generally this is if their systolic is 90 or less. Some other things like you can kind of think about if their MAP is well below baseline. If they have marked bradycardia or tachycardia, if they're having ventricular infarction and some other things. But really the other point besides hypotension is if they've used phosphodiesterase inhibitors, something like Viagra. There's actually 2 different types. Some of them last 24 hours, some of them last 48 hours. But this is a way to kill a patient. When I'm giving mock cases, I will often work this in the medical history. They'll be taking a drug like Viagra for erectile dysfunction. And then we get to the MI part, and I try to see if they understand that they cannot give nitro here. So big star thinking about this in your heart attack algorithm. And then we have aspirin, 325 milligram aspirin chewed. And then we get to morphine. So there's been a number of meta-analyses from the NIH over the last 10 years that have shown increased mortality in people who get morphine and narcotics. That's kind of weird, right? Okay, we want to treat their pain and keep them comfortable. The hypothesis is that when people have narcotic drugs in their system and they go on for the normal management of the MI, particularly the PY12 inhibitors like clopidogrel interact, and that the narcotics prevent those platelet inhibitors from working the way they should. So you'll see this in all the algorithms. If you look at the verbiage for this portion of it, if you go to UpToDate, if you look at anything, it'll have the word intractable pain. So you only want to use narcotics if the pain is intractable. 10 out of 10. Absolutely crushing. My wife, an ER doc, when I ask her about this, is, Tylenol is what she gives folks for their pain management, and then only uses narcotics if she absolutely has to. So do not give narcotics unless you really need to. There have also been several large meta-analyses that show that small doses of fentanyl, something which we have a lot more access and use as opposed to morphine, are equivalent to using morphine. So you could also reasonably, in that situation, if you needed to, give a small aliquot of fentanyl, maybe like 25 mics. And that is okay. But it's interesting. And it's something I keep an eye on about how this ONAM thing changes, right? Because, 5-10 years ago, it was crush them with all these things, right? Get the oxygen on board, get them a lot of narcotics. And then, so it's interesting how it kind of changes. Any thoughts on that from you guys?
Would you use something like Toradol at all? I mean, that's another IV medication that is a non-narcotic. I mean, is there any contraindications to that?
I would not return NSAID, particularly because if the patient does end up getting a PCI or procedure in the very near future, right, goal to balloon time 90 minutes, the inhibition of the platelet effects from thromboxane A2 could potentially disrupt or have effects on the cardiologist's course of action and treatment. So I think that is why that is not part of that algorithm, because if they do have issues, you might be affecting it in an unpredictable way.
Got it.
Nice. All right. Rock right into the next one here. I'll start off. Hypotension. So generally we define this as an abnormally low blood pressure. Certainly depends on the setting in which you're taking care of the patient, right? If you're thinking about an ICU setting or shock, that really is a mean arterial pressure or MAP of less than 65 millimeters of mercury. Trauma patients, our systolic less than 90, we need to get concerned about bleeding. But we have to really think about their age, their baseline, their comorbidities, and what we're doing, right? Our sedation patients often come in fluid down, right? I like to do that fluid calculation. Most of our drugs are vasodilators, so the healthy ones can certainly tolerate, transient hypotension like we see. But remember that core anesthetic principle that we learned during general anesthesia. We really want to keep that MAP and that blood pressure within 20% of their baseline, because the older they are, the more cardiac history and risk then they're prone, if we put that range outside of it, to stop perfusing their vital organs like their brain and their kidneys and all sorts of things, and then cause maybe something like an MI due to a lack of oxygen supply and demand. When we're thinking about preoperative medication management for hypertensive patients, I've talked to plenty of folks who kind of continue everything. I think most of the recommendations, and myself, I like to hold ACE inhibitors and ARBs because they make treating hypotension very difficult intraoperatively. Where most of the other hypertensive meds, and especially beta blockers, we continue because beta blockers have shown a decrease in mortality. Hypotension can present like we talked about, right? Similar to the syncope and dizziness, lightheadedness, weakness, falling down. And if they're sedated, it can get a little bit more tricky. What do we do first, and how do we treat that, Lisa?
Yep, we're going to stop what we're doing. We're going to pack the site and suction. And something good here is always just look at your vitals. If you want to cycle the cuff again, I have a team of nurses. So if it's low, I have them do a manual on the contralateral arm just to verify that reading's accurate. And I always look at the heart rate, because that will kind of send me into two paths depending on what the heart rate's doing. If the patient's tachycardic, I usually like to reach for phenylephrine. So phenylephrine is an alpha-1 agonist. It works really well for hypotension, and it will cause reflex bradycardia. So it will help with that tachycardia. The adult dose for this is 100 mics every 5 minutes. In kids, it's about 2 micrograms per kilogram. In my crash cart, I know when I have this, I need to do a double dilution for this in order to administer this IV. So just something to keep in mind, be familiar with what you have at your office and if you need the dilutions. If you're in the hospital setting and you have the pre-made sticks like anesthesia, that's pretty nice because those doses are usually already diluted for you. But if you have a vial, you likely will need to do a dilution as well. If the patient is hypotensive and bradycardic, I like to reach for ephedrine. So ephedrine is an alpha and beta agonist, so it works well for hypotension and will help with the bradycardia as well. So adult dose for this is about 5 milligrams every 5 minutes. And then again, in my crash cart, this needs a single dilution with normal saline. And something just to keep an eye out in your crash cart as well. And then whenever you think of bradycardia, especially if it's a sedated patient, if you see some other systemic signs of poor perfusion, that's when you kind of forget about these, and then you're thinking about PALS and ACLS algorithms, and those are the pathways that you want to go down.
Grant, any feedback on that, or hypotension management? No, we as surgeons, we see it all the time, I think, just due to the nature of how we provide those sedations. Most of the time it's fine, but sometimes it can get profound or scary.
Yeah. For sure. I know, because you mentioned at the beginning, just people coming in being fluid down. I encourage patients to sip clear liquids up to 2 hours beforehand. It helps with the IV, but also issues like this. I want them to kind of be well, hydrated. So I don't know, just small things to kind of prepare to avoid stuff like this. But no, it's a good one.
Yeah, certainly good. Yeah, because remember, that is how the standard NPO guidelines work. They can have clear liquids, including Gatorade, up to 2 hours before. A lot of hospitals now moving into ERAS protocols to get patients out faster and feeling better. I'll often, anytime I'm doing a sedation that's late morning into the afternoon, I particularly emphasize that to make sure they keep fluid up. But good point. So you want to move us into the next one with hypertension?
Sure. Hypertension is a pathologic dysregulation of the homeostatic mechanisms that control blood pressure. That's sort of Jenzer's one-liner there. But really, it's elevated blood pressure with a systolic blood pressure greater than 130 or a diastolic greater than 80, whichever is based, and you want to base this on the higher average of 2 or more readings on 2 or more separate occasions. So the American Heart Association in 2017, as well as the JNC8, have different stages for this. This is definitely more geared towards boards. But normal blood pressure is systolic less than 120, a diastolic less than 80. You can have elevated with a systolic ranging between 120 and 129, with a diastolic less than 80. Stage 1 is a systolic with 130 to 139, or a diastolic between 80 to 89. And then stage 2 is anything greater than a systolic of 140 or a diastolic greater than 90. And of course, you can have sort of the offsets of this with severe hypertension, with hypertensive urgency versus emergency, depending if the patient is symptomatic or not. This is usually a systolic greater than 180 and diastolic greater than 110. The new term for hypertensive urgency is now severe asymptomatic hypertension. If you have a patient patient with this, it's really good to call over to the PCP, see if they can get in to see them the same day, or send them to the emergency room if you're truly concerned. When you're thinking about the patients who are most at risk for this, older patients, African Americans are more prone to this, males, patients have a higher baseline systolic or diastolic when you see them on their history and physical appointment. Anybody with an elevated BMI, comorbidities with diabetes, chronic kidney disease, excessive alcohol consumption, and again, that same metabolic syndrome like picture that you're thinking of. How does it present? It's usually asymptomatic. So similar to diabetes, you can't really screen for this that well, especially in the early stages of hypertension. So symptoms are really nonspecific, things like headaches, dizziness, chest pain, palpitations, nosebleeds, visual changes. Those are really likely to present mostly in hypertensive emergencies, and they're not really reliable about the presence or the severity of the hypertension. So those are only in the extreme settings. And just because a patient doesn't have those, it shouldn't turn off your radar. What do you have for treatment, Jenzer?
Yeah. Don't forget that in general, management starts with non-pharmacologic therapy, lifestyle changes, weight loss, exercise. There's a range of antihypertensive medications patients can be on. Examples include ACE inhibitors, angiotensin receptor blockers or ARBs, calcium channel blockers, thiazide diuretics. And like we talked about, I prefer to hold ACE inhibitors and ARBs 24 hours prior to surgery, just because it allows you to manage the intra-op hypotension particularly a lot more effectively. When we are doing a sedation, we have a patient who is hypertensive. We need to think about our differential emergencies, right? So when I'm giving mock cases and the patient, you don't really see anything else. They're kind of, moderate, deeply sedated, and I give you a blood pressure of 230 over 150. What are you going to do about that? Well, first, what do you think about in your differential? So we can just have, severe hypertensive urgency or emergency, or just kind of transient. It can also be secondary to something like an MI or a stroke or a PE. So there's definitely some bad things on that algorithm. And if you can't assess the patient and they're not responsive, or you're starting to work through this is definitely a time when I would call EMS because of the bad potential what's on that differential. Here's something where I would reach for beta blockers potentially. So labetalol, one of the third generation beta blockers, that little bit of alpha 1 as well as non-selective beta blocker activity is really good for hypertension and tachycardia. And we can give up to 5 milligrams about every 3 to 5 minutes. The pediatric dose is 0.2 mg per kg. Max dose of 300. Well, if we're getting anywhere close to there, we're in trouble. But a little bit at a time, see how it works. Cautious use in asthmatics, it can cause some bronchoconstriction. Kind of on the other side of that, we have a common beta blocker, esmolol. That is particularly more effective at slowing down the heart rate, and it's more transient. But when I'm thinking about beta blockers, I'm really thinking about using one of those two agents. Labetalol takes longer to kind of work in and get on, but it's more focused on hypertension, whereas I use esmolol more when I'm thinking about a fast heart rate and kind of slowing that down a little bit. There's also hydralazine, which is good for hypertension with a normal heart rate, or bradycardia, because it will cause a little bit of reflex tachycardia. And it's really a direct acting vasodilator. But if you guys know, if you put that on patients in the hospital, it can really cause profound headaches. The dose for that, adults about 5 milligrams, kids 0.1 mg per kg. And watch out for that reflex tachycardia, but good for an asthmatic who is hypertensive. But yeah, really be thinking about that differential, because things like fast or slow heart rate or hypertension, I'm really thinking about what's causing this. Is this secondary to something, some more insidious source or cause, looking at their EKG and trying to figure out where we're going from there.
Yeah, that's a good point. I don't have esmolol in my office, so our requirements are really just hydralazine and labetalol. But esmolol is a nice one too because it's very fast acting.
Yeah. Moving on here, we have hypoglycemia. And so that is defined as a blood glucose concentration less than 70 milligrams per deciliter. And we kind of break it into 3 levels from the American Diabetes Association. Level 1 is kind of between 54 and 70, and this is kind of possible intervention required, might have some minor symptoms. Level 2 is less than 54 and requires immediate action. And level 3 is defined as a severe event characterized by altered mental status or physiologic changes requiring assistance. Obviously, people who have dysregulations of the mechanisms that control sugar and glucose metabolism are most at risk for this. Diabetes of some form, older patients greater than 75 years, people with CKD or end-stage renal disease, people already with cognitive impairment, and people who have a history of severe episodes of hypoglycemia. And again, this inefficient kind of not enough amount of glucose can manifest with some of the similar symptoms we've been talking about. Neurogenic things like shakiness, irritability, confusion, sweating, pallor, can't speak well, things that can mimic or look like seizures, very much so. And all the way up to including loss of consciousness. So how do you treat hypoglycemia, Elisa?
Yeah, it really depends on the level of consciousness of your patient. And I see this quite often in my office, even usually with the older patient who's been maybe waiting for a consult, or some person who comes in NPO who might have took their insulin in the morning on accident. But if the patient's awake and can swallow, you can give them 15 grams of carbohydrates. So if you have like apple juice in your office, you can give them some of that. Your crash cart glucose that you have available to you, you can also have them have that. But they do need to be able to swallow this. If the patient can't swallow, then you're going to start thinking about getting an IV. For an adult, you can give them D50 through that IV that has 25 grams of glucose. You'd expect to see a blood glucose increase of about 100 to 150. And this lasts only 30 minutes. So you want to just keep an eye on them, monitor them, because they might need to be resupplemented. And then 1 gram of glucose usually increases the blood sugar by about 4 to 6. So that's something just to keep in the back of your head. If you have a child, you can give D25. So if the patient is still hypoglycemic and you can't get an IV and they cannot swallow, then you can think about IM glucagon. So these come similar to an EpiPen. They are extremely expensive, something I don't have in my office, but I did have available if I needed to on boards. But you can do glucagon IM 1 milligram in the vastus lateralis for adults, or 0.5 milligrams for children. And then you would expect to see a response in about 10 minutes.
Nice.
A fun game of boards. And even though if you don't have something, now you do.
Yeah.
If you work alone, now you work in a hospital setting.
Yep.
As we wrap up here for the listeners, and if you're getting ready for this, practice writing out how you're going to deal with this. The wonderful thing about doing boards, and Grant, by the way, some great episodes recently about those other guys talking about it, is it makes you a better surgeon, because you spend so much time with all this stuff you might not have had a chance to deep dive in residency. But it cements particularly this kind of stuff we're talking about, which is so critical to our practice in keeping patients safe. Going through and making sure that these are just burned into your memory about what to do, what to consider on the differentials, when to activate your emergency response. And, because when those bad things happen, as we all know, they happen quickly. And the stress of the situation, if you have that underlying foundation, can really make you a more effective practitioner.
100%.
Final thoughts or questions, Grant?
No, I think this has been a good review. Makes me want to go make sure I got all my crash cart meds up to date. My team's trained. We try to do quarterly kind of mock emergencies, just always trying to refresh the memory of the team and make sure we're a well-oiled machine, so that when the crap hits the fan, it's a relatively smooth experience. But yeah, thank you guys for reviewing all this. This has been great.
Absolutely. Please reach out to us and let us all know if more of these kind of mock cases, boards, kind of quick hitter reviews for you guys to hopefully listen to are helpful, and you want more of it. Please shoot me an email if you're interested in the summer thing with Lisa and I and Matt. And strongly suggest, if you're getting ready for this, if you're an upper level resident, because all residents are welcome too, come and check out the St. Louis course or the second edition of the Blue Book when it drops.
Great resources. Thank you guys for offering those courses and working on those books. So awesome. I really appreciate your time. And so thank you so much.
Thanks, Grant.
Have a good rest of your day.
Take care, team. Until next time.
All right. Sounds good. Bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.